So we separate out spine compression fractures from other types of compression fractures because it tends to be present in a certain patient population, and obviously because it's the spine, we're going to be treating it differently than we would with like a compression fracture of the foot or the tibia or something like that. So compression fractures of the spine, they tend to happen at the thoracolumbar junction. So lower thoracic spine, upper lumbar spine. So sometimes those compression fractures can affect ribs if they're further up, so we can end up with irritability of the ribs, possibly maybe a little bit of pain with breathing, those kinds of things. But usually, again, it's the lower thoracic, so we're not really affecting ribs. And usually it's going to be more issues with kind of back movement, lumbar movement, trunk rotation, those kinds of things. So compression fractures usually are associated with osteoporosis. So most of the time we're getting compression fractures because the patient's already been diagnosed with osteoporosis. And or it's going to be in a population that is an older population of frail women, honestly, because those are the patients who have osteoporosis as well. It could also result from trauma, but usually it's these patients, these people that are already somewhat compromised somehow. In this case, osteoporosis is a bone health problem. And so their bones are not very strong already, and then they do something little that's not a big deal. It's not like a big fall or anything. And that little movement that's wrong ends up leading to a compression fracture of the body of the vertebrae. So the most common type is going to be what's called a burst fracture, and I'll go through pictures to show you that in just a minute. But you can see from these pictures that these fractures, a burst fracture, it has kind of a dramatic name because it's literally like the body of the vertebrae bursts out and it collapses the body of the vertebrae. And so that can be obviously a problem for lots of reasons. So 20% of all thoracolumbar injuries are a burst fracture, and it happens in basically 8 to 25% of the patients that have these kinds of fractures are going to be postmenopausal women over the age of 50, and 40% are postmenopausal women over the age of 80. Okay, so again, as we finish menopause, our bone mineral density is not as good. Our hormones, our estrogen is lower, so we're not having this most stable bones at this point. And then as we get older, we might not move as well, and so we're more likely to do, again, these small little traumas that lead to a fracture. So you can see here, I said I would show a picture of the burst fracture. To the right bottom of the picture, you'll see that burst fracture, the example of a burst fracture. Above that is what's called a wedge fracture, and then a compression fracture. So compression means that there's a collapse from overall pressure. A burst is literally that. It's like a crushing of the entire body of the vertebrae. These can be diagnosed pretty well through x-ray. They may do an MRI. And it's important that we get diagnosis pretty early. So again, if there's been something small that's happened, small trauma, and they're complaining of maybe pain with breathing or pain with any type of back movement, then you definitely want to get them in for an x-ray to see if there is this type of compression fracture. So non-operative treatment and post-operative treatment is going to have a similar time frame. Non-operative treatment, some studies will tell you that it's better than trying to do an operation. So it's kind of dependent on the study and the situation. But I would say, in China, I definitely see more patients who have had surgery than haven't. But it's not a significant amount. So it's not like 90% get surgery and 10% don't. It's closer to 50-50 in terms of what I've seen, my experience with surgery or no surgery. Pain and function, sometimes they say is better if they're not doing surgery. With these people, we're still going to do some sort of bed rest for a period of time, but it shouldn't be long, okay? So again, the time frame is very similar as the post-op time frame. They should not be laying in bed for longer periods of time because they didn't have surgery, okay? When they do bracing, we're going to talk about a study actually that really looked at bracing. If they're going to use bracing, they're only really needing to use bracing if you're worried about their movement quality. So most of the more recent research would say they don't need a brace, which is totally not what people say in China, right? Everybody says, oh my gosh, you need a back brace. Get a back brace. Wear a back brace for months, which always makes me frustrated. I know we talked about this when we talked about spine fusions and different types of other spine surgeries, laminectomies, minimally invasive spine surgeries. Bracing is really not necessary, and I'll show you why with this article here in just a second. If they are going to wear a brace, they're wearing it for pain control, and they're wearing it, like I said, in this case, if you're worried about their movement. So this is going to be your patient who cognitively is not very aware. So they're an older person who maybe has a head injury as well, or they maybe had a stroke, or they maybe have something else where you're worried that they might get up and move around the wrong way and end up causing more damage or more collapse of the vertebrae or more, nerve injuries or something like that. Then if that's the type of patient that you're worried for their safety, then I would say you put them in a brace. Otherwise, they don't really need one. So let's look at this research. This is 92 osteoporotic patients, so 92 patients who had osteoporosis. They had stable burst fractures, okay? And you can label these fractures A0 to A3. It basically means that there's compression of the vertebrae, but it's more just the anterior part of the vertebrae, okay? So that's what we say when we say that it's an A0 to A3 fracture. And so what they did was they had one group. Oh, and none of them had neurological symptoms, okay? So these are patients with not the crazy, significant collapse of the body of the vertebrae. Instead, just the front collapsed a little bit. They were doing conservative treatment. One group did no brace. The other group did a brace. The brace that they used is what's called a TLSO brace, which is a thoracolumbar sacral adjustable orthotic, just like the picture that I showed you. And then they basically had both groups do the same treatment, okay? So the first 4 weeks, their treatment included bed mobility, so being able to roll around in bed, being able to sit up, and a lot of walking, not sitting for long periods of time, okay? If you think about it, and we'll talk about this with post-op as well, sitting is going to put a lot more compression and pressure on the anterior aspect of the vertebrae, right? On the body of the vertebrae, because we're in a little bit of flexion. Older people are probably even in a little bit more flexion. So you're going to get compression on those vertebrae, which we don't want. So during the first week, they did bed mobility and they walked. So they were in a neutral or extended back position for that first week. And then from week 4 to 8, they added some trunk stabilization, so some core stability exercises, lower extremity strengthening. Week 8 to 12, they added isotonic trunk exercises, meaning a little bit of side bending, a little bit of rotation, those kinds of things. And then by week 9, they added ADL-specific activities, or if they were going back to work, which most of these people aren't, they added work-related activities. So what they found at 3 months post-injury, so again, these people did not have surgery, both groups demonstrated significant improvements, those with the brace and without the brace. So quality of life, satisfaction, and pain were both improved, and both improved equally regardless of if they had a brace or not, okay? So what the authors conclude is that this type of fracture is inherently stable, okay? There was only 2 or 3 people, I think, in the study who had some pain at the second stage, so at that week 3 or 4. And so they did have to kind of slow down, but that was a couple people in one group and a couple people in the other group. It didn't matter if it was a brace group or not, okay? And so what this group concluded, this was in Spine in 2014, is that with this type of fracture, especially if it's that A0 to A3 criteria, that was the inclusion criteria, that these people are stable. They are inherently stable. Their muscles, their other joints, their other bones around those fractures were stable enough that they don't need a brace, okay? This idea is extremely controversial in China. I understand. If you guys want this spine research, again, Spine is like the best journal in the world for spine, right? So if you guys want this so that you can reference it to talk to your doctors, that's totally fair. And recognize that the bracing versus non-bracing did not affect outcomes at all. Both groups did great. So when are we choosing to do surgery? Surgery is going to occur if it's that A4, I think it's 4, 5, 6. I think there's 6 levels. Surgery is going to occur when there's significant loss of height in the vertebrae. So remember, it's a body of the vertebrae. There's significant anterior height or bulging posteriorly. We know that if it bulges, there's bulging posteriorly, that's going to affect the spinal cord. It's also probably affecting nerve roots more. So when there's nerve possible problems involved, we need to consider surgery. It's also common that people will have conservative treatment for a period of time, not do surgery. After 12 months, if there's still symptoms, especially, again, if there's nerve symptoms, then you're going to probably consider surgery. More than 40% of patients using conservative care get good, like complete pain relief at 12 months. If they're still demonstrating significant pain, like debilitating, I can't get up and walk pain, greater than 6 weeks of conservative treatment, then that's when you want to send them back to the doctor. Again, also if there's any nerve symptoms, spinal cord symptoms like drop attacks, meaning the spinal cord, there's so much pressure on the spinal cord that their legs lose control and they fall. Those kinds of symptoms that are related specifically to spinal cord, obviously that needs surgery. The other challenging thing is, if this is a really bad problem and they delay surgery for maybe 2 weeks or more, then the outcomes are not as good. There is more pain. There are longer hospital stays. So again, as therapists, we're not usually the ones who make the choice about surgery. But recognize that if it's a more significant injury, they're probably going to want to do surgery. And if the pain is significant for more than 6 weeks, then they're probably going to want to do surgery. So let's look at the surgery. Let's see what they're doing here. This is the most common. There's different ways they can do this, but I would say this is the way that I've seen it most in China. So this should be what you guys see as well.
This animation illustrates the treatment of a vertebral compression fracture of the thoracic vertebra. Compression fractures may occur as a result of trauma or due to conditions such as osteoporosis. 2 small incisions are made in the skin to allow instruments to access the collapsed vertebral body. A small tube introduced to each side of the vertebral body through the pedicles allows the balloon to be expanded inside the body. This restores some height of the collapsed bone. Cement is then injected into the vertebral body to fill up the cavity left by the balloon to secure its structure and prevent it from collapsing again. By stopping further collapse and stabilizing the fracture, pain is improved.
Okay. So this is also kind of giving you that information. If it's a really bad problem, you'll see that they will use internal fixators. So they will even probably like almost do like like the metal bars and things that you might see with a spinal fusion. That's possible. Basically, they if they can go in percutaneously, so what's called a percutaneous kyphoplasty, then there's less possibility of cementage leakage. And so the way that they do this is essentially what you saw, where they put a balloon in, they inflate it, they make it big, they put the cement in, and then it's able to stay more stable. So that's kind of the most common procedure that you'll see. So this kind of shows you a picture. You saw the video. The video's, I think, pretty helpful to show you how they go in and then they put that cement in. And so you can actually see the cement in x-rays. So you can see that what they did where they went in and just basically opened up the space in the body of the vertebrae, made it higher, increased the height, and then filled it in with that cement. So complications, just like with everything else, I think you guys are getting sick of seeing the same complications. Infection and deep vein thrombosis can definitely happen. Pneumonia is another possibility. I think mostly because these people are laying in bed for too long, and remember they're an older population, and because it's the thoracic spine oftentimes, it's usually lower thoracic, but they get scared about breathing deep breaths. They get scared about moving through their thoracic spine, and so they end up having these shallow breaths where they're not getting full tidal volume of their lungs. So we talked about rib fractures. You could go back and listen to the rib fracture recording, or if you haven't listened to it yet, we talk a lot about breathing techniques. This group is probably another good group to think about making sure they're doing good breathing techniques to decrease the likelihood of pneumonia or the likelihood of pulmonary embolism. That's not something we can really treat, right? We can't treat pulmonary embolisms, but we want to make sure that we're getting good tidal volume, good breathing technique. Decubitus ulcers are going to occur because, again, they're not moving enough. They need to be moving. And you'll see that in just a little bit. Infection can also occur. We already said that. And then asymptomatic cement leaks. So the cement can leak. Usually it doesn't affect anything. Usually people are not going to notice it because it's not going to go into like a spinal, like the spinal cord or a nerve root or anything like that. But the leakage does happen. So I want to present to you guys this really nice protocol from Physical Therapy Journal called Build Better Bones with Exercise. And I'm just sharing one slide with some suggestions. But this is a couple of years old now. They basically looked at patients who have osteoporosis and had a history of spinal fractures and kind of put together suggestions for exercise. So these are patients, this could be used post-operatively and non-operatively as well. And so you'll see here what they do is they give you sort of like the exercise. So in this case, it's like sit to stand or squat. And then they show you level by level how to make it more difficult and then also how to modify it. So with sit to stand, you just do it 5 times, progressing to 10. And then you actually make the squat lower. You can do things like wall squats. For standing, hip extension, abduction. And then there's step ups and there's lunges here. So all of these things you'll notice are in weight bearing, and they're all kind of focused on extension. So again, thinking about the fact that when we go into flexion, we have more pressure on the body of the vertebrae. So we really want to stay away from flexion activities, flexion positioning for anybody who is osteoporotic, but especially with these patients who have a history of some sort of vertebral fracture. So this just gives you an idea. Here you can kind of read through it, these different options of exercises. They also have some upper body exercises like wall push-ups, things like that. Again, everything is either in standing. Quadruped is also a great position because, again, we're trying to increase trunk, lumbar, thoracic extension. So these are just suggestions. Let's talk about specifically what we want to do with these patients after surgery. So phase 1 is only 1 week, okay? It's a short phase. At this point, we're definitely spending a lot of time on pain management. We want to make sure that we're also decreasing fear. So we want patients to know that movement is good, okay? That immobility is bad. I'm going to say it over and over again. You're working on bed mobility. You're really focused on making sure that they can roll in bed without doing a lot of twisting. And you're also focused on trying to make sure the lower extremity mobility is good. So knee flexion, extension, dorsiflexion, hip mobility, rotation, things like that. So, hey, patient education, bed rest is bad, okay? So this is true before, after, all the time, okay? We want to make sure that they know that laying in bed is not going to be helpful for their outcomes. So first initial treatment, again, this is just that first week. After a couple of days, you can start doing sit to stand, but you're not sitting for very long, okay? So you're spending time on standing balance, you're spending time on walking. You definitely want to do gait. Look at this, gait starting at day 3. Gait can be definitely, you can use an assistive device, okay? So a lot of patients will be happier using a walker. It's probably, you're gonna appreciate a rolling walker more than a standard walker, so you don't have to pick it up and move it, but they can roll the walker, and that's fine. They can unload a little bit with their hands, but you do want them walking in that first week, please. And it doesn't mention anything about bracing. I know that. It shows abdominal bracing, so that's the muscle, right, the exercise. But for bracing, again, you don't have to wear a brace. If they want to because they're scared or because of pain, that's fine. But the idea is we want to get them out of the back brace as quickly as possible. So progressive loading, so week 2 to 4, this is when our goals are to be able to control pain with upright positioning. So standing, we can start doing a little bit of sitting, but sitting for short periods of time. They also need to really understand good body mechanics. So practicing sit to stand with basically low back extension and trunk extension. So they should not be bent over in that really bad like kyphotic thoracic posture when they're doing sit to stand. You want to make sure you're teaching them how to get nice extension. And we're walking. So we want to make sure they're walking without deviations. I think the only reason you would see a deviation would be if there was some sort of nerve damage with the fracture. You might also maybe see a deviation of like a Trendelenburg if they're just very weak, or again, trunk posture, they may have that kyphosis. But so these are all things we need to try to decrease during the second phase. if it's appropriate, you do want to talk to your patients about osteoporosis. Hopefully, I've found that most doctors are pretty good about doing education, or nurses or somebody's educating them on osteoporosis. And hopefully they know they're taking supplements, because obviously calcium supplements and estrogen supplements or whatever they need to take, whatever you guys are recommending, doctors are recommending these days, is important. And just helping them recognize that things like drinking too much alcohol can definitely decrease bone health. Steroids are not a big thing. We talk about steroid use. I talked a lot about that with tendon issues, because we don't want tendon health is definitely affected by steroids. You guys don't use a lot of corticosteroids in China, so it's probably not as big of a deal. Smoking isn't good, and sedentary lifestyle is not good for osteoporosis. So just talking to them about those things, making sure they know that that's true. During the treatment, so weeks 2 and 3 and into 4, we're continuing to work on core stability, lots of walking, lots of hip extension. You can start, hopefully at week 3, you can start doing a little bit of prone activity. So again, you can really work on back extension by week 3 or 4. And then quadruped is also a wonderful position to get these guys in. So doing things in quadruped, it works the whole body, and it's great weight bearing for the hips and the arms and the spine, all of it. So by week 5 to 8, we can start doing more advanced activities. We want to make sure that they have good body mechanics with everything that we're doing. So really trying to focus on, okay, is their movement pattern look normal? We want them to get back to all their ADLs at this point. So, getting off of a toilet at this point should be relatively easy. More demanding activities, if they love to play sports, then you're starting to prepare them for that. And their balance scores. So we want their Berg balance score to be greater than a 44. So remember, Berg balance is out of 56. A 44 is, they're relatively safe, especially with an assistive device if they're measuring at 44, but there's still definitely a fall risk, even at 44 out of 56. So you're hopefully going to be spending a good amount of time on balance activities so that they don't fall again and cause another fracture. And so this is kind of our goal by the end of phase 3. Unfortunately, we didn't really talk about this with the complications. This isn't really a complication, but what the research has shown is that after a fracture, the possibility of increasing thoracic kyphosis becomes higher. So they're more likely to start getting into that bad posture where they're kind of bent over. So we really want to educate the patient on, we've already said educate them on movement patterns, but also just on static postures. So this is especially true, that kyphosis is especially true if the fracture was at the thoracolumbar junction. So just like this picture, if it's at like T12, L1, they're more likely to become more kyphotic. And if it's what's called a wedge type fracture, so again, that really big collapse in the anterior part of the body of the vertebrae, they're more likely to be kyphotic. So you want to spend a lot of time teaching them how to do scapular movements, how to do upper thoracic extension, so that they're not ending up with that kyphotic posture in the long run. So we said we're progressing to more prone exercises like Supermans, things like that. Bridges are not something that I would be doing early. Think about when you do a bridge, how much compression could occur on the vertebrae, especially at that thoracolumbar junction. So you're probably not doing a whole lot with bridges the first couple phases, but by this point you can do bridges. I would much rather do that kind of those hip extension activities and standing. So if you remember in the first phase, we were doing standing hip extension. That's fine, but the bridge is a lot more compression on the vertebrae, so we're waiting to do that until phase 3. You could also do things like planks against the wall, and then we're increasing walking. So lots and lots and lots of walking. After about week 9, so again, this is relatively quick, 2 months, okay? Following these fractures, these guys should be getting back into sports. And we do want this group to be doing sports. If they have osteoporosis, then weight-bearing activities, strengthening, walking, any of those things can be really helpful for bone health. So we want to be making sure that this group has a good exercise program that they can be discharged with. They need to feel comfortable with very specific prescription of things like either walking, dancing, swimming, those things, and they need to be doing at least 15 minutes per day. And I would say they're progressing, to 30, 45 minutes per day. Walking in China is by far the easiest one to do, but a lot of older people love swimming. Swimming is awesome because of that extension. So if they can do swimming, that's great. Again, anything that they enjoy, that they will continue doing, is going to be helpful. So you've got to motivate them to keep up the activity, along with balance exercises. So playing with balance exercises and weight bearing. Obviously, balance exercises are in weight bearing, but working on those with them is going to be a really important piece of, actually the most important thing that you can do for these patients at discharge is giving them that home program.